Welcome everybody, and thank you for joining us for the last Dementia Australia webinar for 2024. How quickly the year has gone. Today's topic is delirium and dementia. My name's Gary O'Toole. I'm the National Consultancy Lead at the Centre of Dementia Learning at Dementia Australia. Just first up, I'd like to acknowledge the traditional owners of the lands on which we all meet today. I'd like to pay my respects to elders past and to present, and to our shared futures. Today, we're really fortunate to have two very esteemed guests with us. First, we have Dr. Mark Yates, who's the Associate Professor in Aged Care Rehabilitation and Palliative Care at Deakin University, and also Consultant Physician in Geriatric Medicine at Grampians Health Service. Mark brings a wealth of experience and knowledge in the field of geriatrics, and he'll be able to provide us with some really valuable insights into some of those medical aspects, I suppose, of dementia and delirium, help us to understand some of the key differences between these two conditions that affect cognitive functioning, and also guide us in best practice in the management of delirium. Our second guest is Len. Len's a dedicated family carer who has first-hand experience of caring for a loved one with dementia, who also experienced delirium. Len's also a Dementia Australia advocate and is playing a really important role in a Dementia Australia Research Foundation program looking at delirium and dementia. Len's going to share his personal journey, and we know that he'll be offering a unique perspective on the challenges and rewards of providing care. Just a little housekeeping as well. Just a reminder that your cameras and microphones have been turned off for the duration of the webinar. If you've got any questions, and we hope that you do, or any comments, please just pop those into the chat box on the right of your screen, or if you look up on the top of your screen, there's a little chat button. Our team will be monitoring the question and answer box, and if a question requires a direct response, we'll get onto that immediately. Otherwise, it'll be published for the whole audience to see. We really encourage you to like the questions. That will help us to curate those. After today's webinar, we'll also collate the five most liked questions, and we'll send those off to our panel guests for their comments, and we'll be able to send those on to you later. So just to start, I'd like to turn to Len. Len, I wonder if you could share with us some of your personal experiences in caring for somebody who had both dementia and delirium.
Yes, thank you, Gary, and hi to Mark and all you lovely people out there in Teams land. My wife died last Christmas, 2 days before Christmas, and delirium was listed as one of the causes of death, along with dementia and a few other bits and pieces, including pneumonia acquired in hospital. The point is, I didn't know she had delirium because it wasn't the delirium that I, as a layperson, might expect. It wasn't agitation, it wasn't aggression, it wasn't huge anxiety and confusion. It was simply episodes of almost a catatonic state, so unresponsiveness. And she would sit there perfectly normally, but not responding to touch, not responding to words, not responding to visual indicators at all. And these episodes were becoming more frequent and of longer duration. The clincher came 2 weeks before Christmas, when we were sitting in the communal lounge. I live in a retirement community, so there were other people in the lounge as well. And 1 hour stretched to 2 hours, stretched to 3 hours, stretched to 4 hours, by which time my neighbours, those in the room, were becoming a little anxious. far more anxious than I was because I'd seen this before, although not to this sort of duration. I just thought she would snap out of it and be her usual Barbara. But finally, I was persuaded that we did need some medical intervention, and the ambulance was called. The paramedics took all her vital signs, which were good. So to all intents and purposes, there was nothing wrong, except that she was still unresponsive. And that was when the word delirium was mentioned to me for the first time. So this was, I presume, Mark will either confirm or not confirm this. I presume this was a delirium episode, and there had been episodes of that kind previously. So off to hospital she was whisked. Again, the doctors looking at her there decided it was delirium, and she was kept in. I expected to get her out. I didn't know how delirium was going to affect a dementia patient. And as I say, I just thought this was another symptom of dementia becoming progressively worse. So she did snap out of delirium, but she also lapsed into it while she was in hospital again and again. And 2 weeks later, she was dead. So that was an experience of delirium stroke dementia that came to me unexpectedly, because I had no prior warning, despite all my research of what dementia management meant. I had no prior warning that delirium could be an aspect of dementia. I now know that it is a separate disease, that it can be brought on by infection, that it can be treatable, and that we should differentiate between dementia symptoms and delirium symptoms. So what I'm saying is that as a carer, I think I needed more information.
Absolutely, Mark. I'm interested, Mark, Len, what sort of support did you get from the healthcare professionals? So the people, the first responders, people at the hospital?
I would say none. There were no explanations forthcoming. I mean, obviously, when you're taken into an A&E situation, it's pretty chaotic. It's busy. That's not the best place for a dementia patient to be under any circumstances. And we're just, I get annoyed because they're not getting any response from my wife. They're asking her questions to which she has no answers. Her brain is not working quickly enough to digest what the question is. There seemed at the time, from all the medical professionals on hand, to be no understanding of how to deal with dementia, yet alone how to differentiate between delirium and dementia. So there were instances, for instance, when they simply raised their voice. There's no response coming. So as if somebody is deaf, we raise our voice until finally we get mildly exasperated because there's still no response. So I was not happy, but it was not the first time I had witnessed that sort of experience in a hospital setting.
Len, it's really interesting. I think one of the things I'm hearing from you is that probably we need better education, both for family carers, for the general public, but also for healthcare workers around this whole area, particularly when you get that combination or the of dementia, of a diagnosis of dementia and delirium. Thanks for sharing.
That's why I've shown an interest in this field, Gary. Yes, I couldn't agree more. We need education. In order to educate, we need, within the lay person audience, we need to have people like myself explaining to other people like myself the sort of story that I've just told.
Thanks for sharing that, Len. Mark, I might throw to you, perhaps stepping aside from the argument or the discussion about the need for education everywhere. I wonder if you could just give us some of that sort of foundational knowledge that we need to know, the difference between delirium and dementia, how they present, or particularly in delirium's case, how it presents, and what some of our audience need to be looking out for.
Look, thanks, and Len, I'm sorry to hear your story as a hospital-based clinician who's spent I think now nearly 15 years promoting and developing and studying the Dementia Care in Hospitals program, which is a national program to support people with dementia in hospitals. Your experience always hurts because clearly we haven't got the message everywhere. So going back to your question then, Gary, thank you very much for that. It's a really difficult, it's difficult and it's easy, let me put it like that. And I think as we approach the 1,000 attendee mark, I'm getting terribly excited. I think the majority of those people online are healthcare workers, probably in the residential aged care sector, where I think the job is even harder. Because as dementia progresses, and I'm sure this is part of Len's experience with his wife, then differentiating between dementia and delirium is more difficult, because cognitive function can begin to fluctuate in very late dementia. And fluctuation in cognitive performance is the fundamental hallmark of delirium. So let me explain that difference. So delirium is a condition, and it's not a diagnosis, it's actually a syndrome. And I think it's best managed or thought about like a brain failure. We sort of understand the concept of heart failure. I mean, that's pretty common community knowledge, and there are people whose heart seems to do okay, they're on a bit of medication, they see their cardiologist, but the minute they get pneumonia, or not pneumonia, let's say they get a urinary tract infection, nothing to do with their heart failure goes a whole lot worse, and they're much more breathless, and everything seems to fall apart. And that's because the infection causes the blood vessels to dilate because it's a fever, and the heart has to work harder. And now we've just hit the heart with extra work that it can't reach. It can't manage that load, and we have the symptoms of heart failure. The brain is a pretty simple organ, as said by a geriatrician. It's there to tell us who we are, where we are, and what we're going to do next, if you think about it. If we didn't know those three things, our brain drives us either to be anxious, cross, or go hunting. And we can induce delirium for all of us if we try hard enough, and there's quite a few people who are at the Melbourne Cup races who induce their delirium very effectively. And we say people with brain injury, for instance, you can't drink so much because you will get more confused more easily. And so in a person who has dementia, whose brain is already doing its utmost to know who it is, where it is, and what it's going to do next, if you throw in something like an infection which stresses the sensory systems and causes pain, constipation, urinary retention, then that brain just gets really distracted, and that's what sets up the delirium. And in that, we describe delirium as fundamentally the hallmark is this fluctuating change of attention. Now that could be someone who's really agitated because they're trying to attend to things, but they're going this way, they're going that way, they're going somewhere, stop this, stop that, don't leave me alone, la la. Or it could be someone who's half asleep. And nursing staff in hospitals love the latter, the hypoactive delirium, because they do everything they said. Would you like a drink? Yeah, but they don't drink. You know, would you like to get dressed? No. And that's fine. They just get pneumonia and then they get into trouble. The agitated deliriums, certainly in nursing homes and in hospitals, get lots of attention because they're causing a ruckus. And they never get pneumonia, but they do fall over. And so the difference, so delirium is an acute change to a brain where it's no longer able, the brain itself is no longer able to connect consistently with the environment that it's in. And that's what leads to the strange behaviors that are described. When they're not behaviors, they're just a brain trying to work out what to do in the environment that it's interpreted. This isn't my home. Where am I going? And yet yesterday, Mary was fine. She was quite settled in the nursing home. But all of a sudden that changes and she becomes a little more irritable, a little more agitated, not able to focus her attention, and then is asking, and by the time the afternoon comes, she's agitated and frustrated because she doesn't recognize her environment. And then we begin to see that. So those, the thing to identify in certainly in the residential aged care setting is change. People are with dementia do have memory impairment. They are different because of their cognitive impairment. But when that changes over a 24 to 48 hour period, be that behavior, engagement, ability to use a knife and fork, or any of those things, then that's when we should be thinking this person might have a delirium, which is important because it might be indicating a condition that we can make better, whether that's a urinary tract infection, constipation, a change in medications, even psychosocial stress can actually do that. If a person's really distressed or depressed, depression can look like can have this sort of change, and so that's an important marker. And as an example of how effective it was in the COVID era in nursing homes in Victoria, we used a marker for early onset of COVID, and it wasn't anything to do with the temperature. It was have this patient changed. And it was a very, very effective marker to minimise the risk of contagion within nursing home, because as soon as someone changed, they got a COVID test, and we identified people quite early, and that was effective in Victoria, and actually studied and proven.
There's some really interesting points, Mark. I love that comment about the different types of delirium, hypoactive and the hyperactive delirium that perhaps some of us are a little bit more familiar with. And also the comment you made about it's about change. We don't need complicated assessment tools necessarily, though they have a place. But, you know, that question, has this person's functioning changed recently, and particularly I think for our audience who are supporting people living with dementia all the time, it's that change that's the alert. I have heard in some of the things I've read about delirium the idea that, and this is a bit of a shocking idea in some ways, that delirium is a medical emergency. I wonder if you can talk a little bit about that. You may or may not agree.
No, I fully agree with that, especially in the hospital environment as opposed to the residential aged care environment. Either way, I think it's still an important marker of a change in someone's physiology, a person's physiology, because you don't get a delirium without a trigger.
Yep.
The question is then how medically dangerous is that trigger? So some people get delirium with constipation, which isn't necessarily a medical emergency, but it needs to be addressed.
Yeah.
Having said that, with delirium, their risk of falls is incredibly high, and that is a medical emergency on the way. So we want to try and avoid injury to our patients, particularly in the residential and hospital settings. And so to identify that delirium and treat it as a medical emergency, I think just identifies the importance of this as a marker of potential risk to our patients. And then we need, then the response is, certainly in some hospitals, and I think Len would agree with this, everybody who's old should be confused in a hospital. That is completely inappropriate, because confusion is not part of normal aging. It is not part of normal aging. And so any older person who is confused either has a known and established dementia, a new delirium, or potentially an undefined dementia with a new delirium on top, and that needs to be sorted out. So in hospitals now, we've defined delirium as a point of escalation. So it's one of the 6 now vital signs. for escalation, and will be under the new national standards, which are being established now. So hospitals should all be monitoring for delirium. And hospitals now, this is to Len's advantage, will be penalised if they have a high risk, a high incidence of newly acquired delirium in hospitals, because it's perceived that delirium is preventable, which it is.
And we might have a chat about that area a little bit later, because I think for many of our audience, well, for me as well, that was a particularly new piece of information, that we could actually prevent delirium in older people. But at the moment, Mark, I'm just wondering if you could talk about, once the delirium has been identified, what the treatment options are. And something at the back of my mind is that the idea that a person can have multiple precipitating factors for the delirium at one time. We all tend to think of a urinary tract infection, for instance, as being the cause, but and we treat the urinary tract infection, but the delirium continues. And perhaps we're looking at multiple causes of the delirium. So I wonder if you could just say a little bit about the treatment and the investigation of delirium.
Yeah. So there's two aspects, isn't there? So first of all, I think that we have to say, well, there's an investigation to look at precipitating causes of the delirium, and then there's the management of the brain's response to its inability to identify and connect with its community or its context, which then leads to a set of misinterpretations or distress to the patient. So the first thing is, why has this patient developed this problem, this brain failure problem called delirium? And then we've got to look for those precipitants. The precipitants could be medical. So if you take the very medical model, it would be things like constipation, pain, urinary tract infection, urinary retention, a change in the body's salt and electrolytes, maybe a new bleeding that nobody's found because it's in the bowel and hasn't been identified anywhere else. So if someone has a delirium, there are a suite of standard investigations called the Jerry suite, which I don't like, but it's a standardized set of investigations that will always get, or should always get done, for someone who has got a delirium that we can't identify the obvious cause for. And I think GPs are pretty good at doing that when they find that. Most nursing staff will then dip the urine and look for nitrites or look for a urinary tract infection. Mm-hmm. I think the risk there is that we know that older people actually are colonized by bacteria, and sometimes that's not the cause of the delirium. Mm-hmm. So a positive urine isn't always the only answer, as you said, so we might need to look further afield. But if there is a urinary tract infection and it's there, then treating it's probably a useful thing. Then the next question really is, how do we go about, if we can manage that condition, why, if we've given the antibiotics, aren't they better? Well, there's a woman by the name of Jane McCusker who did longitudinal studies with patients who had delirium in hospital and were sent home. The average length of the delirium was 6 weeks. Mm-hmm. So this concept that delirium they get it and then they're better in a couple of days and everything's back to normal is actually not true. It does persist for longer than people expect, particularly hospital staff who send people back to nursing homes still with an active delirium and expect the nursing staff to manage that, without giving any indication that delirium is still present. And so that is probably why the delirium persists, but also we have to remember that if someone gets a delirium, and again, I'm going to be harsh on my hospital colleagues, 28% of all new antipsychotics introduced to older people who live in residential care are introduced in hospital during an episode of delirium. And then we've now got antipsychotics that have been used, and even if they've been stopped, they prolong delirium. And so again, the patient comes home with a prolonged delirium back to the residential aged care sector, and sensible GPs are saying, no, I don't want to use antipsychotics, and nursing staff are going, oh my God, how am I going to look after this patient? So that's the first thing. Then what do we do providing the psychosocial support that might help that brain connect back with its usual context? And here I love the concept of a cognitive anchor. Mm-hmm. If we think about kids, right, this is not always a safe analogy to make, but kids basically are small brains that haven't been myelinated up. So they're actually easily fail quite quickly. And if you ask most mothers of 2-year-olds, they know come 4 or 5 o'clock, then there's pasta all over the ceiling, because that baby has no longer connecting with their environment because they're exhausted. They're cognitively exhausted. So the cognitive anchors are family. They are familiar environments. They are favorite meals or smells, anything that can help bring that person back to a connection with their context, and they can feel safe. Because most people if you ask people after dementia who remember, and many people remember their dementia, many of them are either deeply embarrassed by what's happened to them, or they say they were terrified, or they were horrified by the way they were managed by the staff. And so I think the management of the delirium, once we've done with the medical stuff, is to try and build that cognitive anchor and support around the person so they can know where they are. Sleep is important. Pain management is important. Hydration, really important. So there's absolute and very clear-cut evidence that patients who are dehydrated are much higher risk of having delirium. So in hospitals for the fractured bones, the orthopedic surgeons are now very keen and anaesthetists to make sure people are well hydrated as they go into their theatre, so they're not dehydrated when they come out, because the delirium risk is higher. So you asked about, well, what do we do? Well, we do the standard investigations and think about precipitants. And we said pain, infection, distress, constipation, etc. Then we look for those things that we can manage medically, which are probably fairly small. Understanding if we do introduce medication, the delirium may persist for a long time. And then what can we do to support that individual? And particularly, I like to talk about their brain, because it sort of takes it away from that's a naughty person or that's a person who wants to be irritable. It's not. It's their brain not able to deal with their environment, and how they respond to that has personal context for that patient. I mean, if they're a controlling CEO and they've no longer got control, they're going to be very, very unhappy about their environment. Mind you, if they were a beautiful Greek grandmother who just went along with the flow, they may not be so fussed about the world going past and not being quite so connected with it. So they might be beautiful. So I don't know, but that's really what we see.
Mark, some really interesting and important points there. I think that the importance of, for our audience in particular, I suppose, just being alert for those changes that may indicate a delirium on top of the dementia. The importance of not just assuming that the person's cognitive function has changed because they have a diagnosis of dementia, and very quickly getting onto those medical investigations. But I love that idea of a cognitive anchor, those sort of psychosocial things beyond the medical treatment that can really help that struggling brain. And I know what that feels like sometimes, that struggling brain just reconnect and stay anchored. I think that's a lovely idea. We might, Jess, if you're there, have there been any questions from our audience?
Yes, there has been, and this one's probably for Mark, but a couple of audience members are interested in knowing what are the pathological changes that are going on in the brain when a delirium episode is occurring?
When I have my Nobel Prize for delirium management, I'll be able to tell you we don't actually really know. So there have been a number of papers looking at inflammatory markers in the body, interleukin 6, interleukin 4. There is a very interesting study now being done in Sydney by an investigative team led by a guy called Gideon Kaplan, who was the author of the National Delirium Guidelines, looking at insulin and glucose infusions, because there's some concern or an idea that somehow the brain's no longer able to get glucose into the brain cells, because the brain is an obligate glucose metabolizer. It can only metabolize glucose for all its energy. So no glucose, no brain function. And so if cells for some reason can't get the glucose in, They are wondering whether if we give people an infusion of glucose and give them insulin, which drives glucose into cells, then would that help? And we don't know the answer to that yet. So that's really as good as I can get. What we know, the only other thing we know about the pathology is that, and this comes from work by a woman called Sharon Inouye, is that the brain has predisposing factors, which we've sort of talked about, age, dementia and things, and then there are the precipitating factors. And that goes back to this concept of the brain failing. Is so if you've got a lot of predisposing factors like visual impairment, hearing impairment, dementia, previous strokes, etc., then high urea, then in fact those things obviously are risk factors that we don't quite understand. I can explain the visual and hearing impairment, and that comes back to the cognitive load that we're expecting this brain to deal with. If it's got to try and interpret what's happening around it and it's got visual impairment, it might make up a whole lot of stuff when it can't, when it doesn't know what to do. So I can't give you a pathological reason. I tend to go back to this teleological descriptor of trying to understand the brain as an organ rather than as a person with intent to be difficult or distressed or agitated, but understanding the brain does not exist in a vacuum. If you didn't know who you were, you would go asking. If you didn't know where you were, you'd say, where am I? And the only time we allow our brains to live in a vacuum is when we paid $3,000 for a week to sit on an island in Fiji. And actually, we pay big money to allow our brains to switch off, to drop our cognitive load. And if the cognitive load is high already for a patient because they've got visual and hearing impairment, and then they get something that insults their ability to deal with that cognitive load, whether it's infection or distress or constipation, then they can appear, the brain just starts to become delirious. And as I said, 2-year-olds at 4 o'clock in the afternoon, I think, would otherwise be better described as delirium, but we don't say that.
Thanks, Mark. Len, I might just throw to you. Any comments about what you've heard so far?
It's fascinating, Gary. I really thank Mark for a very lucid explanation. I wish I'd known then what I now know. What I'm hearing is that dementia is not a trigger for delirium. It may be a risk factor. What is happening is that dementia is masking the triggers that are causing delirium. And certainly from what you've now told us, I know that my wife was exhibiting delirium symptoms before she went to hospital. So had I known that, then we could have taken different management procedures. We could have had some discussions with the GP. We may have been dealing with a UTI. We may have been dealing with whatever the triggers were, a multiplicity, one would think. But some action could have been taken. And in doing that, we might have relieved some of the burden that my wife was suffering, which really is an additional factor to dementia. It's bad enough living with dementia.
Absolutely.
It's worse still when you have something else, which I now understand is treatable. So it comes back to people in my situation, that is the family carer, knowing more about it. Now I'm an intelligent person. I'm a former journalist and PR consultant. I know how to research. And believe me, over the 6 years I was caring for Barbara, I was a very good researcher. And yet I did not understand the relationship between delirium of the type that she was exhibiting and dementia. So we need education on all sorts of levels.
Thanks for that, Len. Some really important points. Again, education across the board for healthcare workers, regardless of the setting they work in, but also for family members. I'll just take a brief minute just to let people know. We'll post some links in the chat. Dementia Australia and the Centre for Dementia Learning does have a 3-hour training session looking specifically at some of the things that Mark has been talking about in terms of the identification, diagnosis, treatment, and follow-up prevention and restorative care for people with dementia who experience a delirium. We'll also pop in a couple of resources. There's a New South Wales program called CHOPS. I've thrown in some information about Mark Yates' work at Grampians Health. Mark, I think you were involved in developing the cognitive impairment identifier that still I see is in use in many places, plus also some of the clinical care standards that are available just to provide people with a few resources.
Yes, Len, sorry, yeah, I've just finished, I just published the outcome of the larger national study for the Dementia Care and Hospitals program, which looked at hospital-acquired complication rates. Didn't change hospital complication rates, but it did demonstrate that hospital staff were able to learn a strategy, engage with patients and families, involving carers, all the stuff that Len was worried about. So, the Dementia Care and Hospitals program has got a really substantial website, which is on Grampians Health. But if you just look up Dementia Care and Hospitals program, you'll get access to it. Then the ethos is not that we just put a sign over someone's bed. That would be an antithesis to me, but that actually we use that alert to change the hospital culture around the care and management of people with cognitive impairment, and I think that's where all of us that's where we'd all like to be, and we're not there yet, as Len's experience describes to us.
Well, if I can just interject there, I think in certain circumstances a sign over the top of the bed might be of some value. This patient is living with dementia, do not shout.
And we found that, in fact, if we did have that alert over the bedside and there was hospital training that went with it, and an expectation that there would be a change in response, and the change in response was written on the back of that alert, so families could take it down and just read it. And it did two things. One, it held the hospital to account, because if you put alert over someone's bedside that you're going to change the way you respond to the needs of that patient, then there's an expectation that you should, and carers are great drivers of that, because if they see the sign, they ask the nursing staff, why have I not been invited to participate in the discussions about my mum? And secondly, that the other care staff, not the nursing staff, know, but that doesn't get shared with the cleaners who go under the bed and make a noise and take a move shoes, or the menu clerk who say, what do you like to have today? Fill out the order form. Well, hang on, there's the sign over the bed. I'm going to need some help with that. Oh yes, I'll get the nursing staff to help you. So it actually becomes an all of hospital program, rather than just hidden behind on sheets of paper and electronic transfer documents that this person needs additional assistance because they have dementia or delirium.
It's an interesting point, Mark, that it's all staff who needs this education and information. I recently did some work with one of the private hospitals in Melbourne, and we discovered that there were about 30 or 40 people wandered into the room of a patient over any 24-hour period. Then again, across the board, support services, nurses, allied health, doctors, and very frequently nobody introduced themselves. They just popped in, did what they wanted to do, and we're wondering why the patients are throwing things at them. So across the board education is really important. Mark, if I can ask you another question, and I think it's one of the perhaps neglected areas in delirium support in a neglected area, and that's the idea of post after we've treated the various causes of the delirium, and you've sort of mentioned this in passing. What can the people listening to the program today do to assist people to return back to their, as much as possible, their normal level of functioning following an episode of delirium?
I think there's, I'll try and, I think first of all, ensure that the management of the precipitating factor is continued in the home environment. So, I mean, constipation, urinary tract infections are quite common and can recur. And so maintaining good bowels and bladder and nutrition are really important things for anybody's recovery from any illness. So it doesn't really have to be delirium. Then I think that there is we now know that if you want to prevent delirium in hospital, you need to cognitively engage with the patient, make sure they're eating properly, ensure they're exercising and can get up and about. And at home, if someone's a bit agitated with delirium, often people leave them alone. And sometimes you actually need to be involved in some of that support for them so they can be active through the day, which then helps their sleep at night as well. But to be honest, delirium has a course of its own, and supporting and being willing to understand that it'll fluctuate as well. So sometimes everything looks fantastic, we're over it, great, we're over it, it's fantastic, and then a day later you have a really bad day. And that's not necessarily a backward step, it might be part of that fluctuation. And then those fluctuations get less and less. The other thing is not to give up. I sadly see a number of people go to residential aged care because they've had a persistent delirium.
Yeah.
And in fact, they haven't been given the opportunity to make a full recovery. And that's not a bad thing for some people. I'm not an advocate for that everybody should be at home forever. I think we're actually selling ourselves as a community a fallacy that actually is not in the best interests of some individuals or their families, despite what the federal government would like to say. So I think some people do need to go to residential aged care, but what I don't want to see people is go to residential aged care before that's necessary because nobody realised their delirium was persisting beyond 3 or 4 days. And then, oh, well, they're going to be like this forever. Or often families misinterpret it as because that delirium was emerging maybe even 2 weeks before the critical fall happened. And there's a perception that that's a dementia just getting worse and worse. And I often say, well, how is the dementia? Oh, it was terrible. I said, well, tell me a bit more about that. And they say, well, yeah, he was throwing things and everything else. I say, well, how long had that been going for? Oh, just the 2 days before coming into hospital.
Yeah.
Okay, so tell me a bit about what the dementia was like. Oh, well, he was pretty good up until about a month before he went into hospital, and then it seemed to all fall apart. So getting that history is really, really important as well. So we've talked a bit about managing the precipitants, then thinking about how we can support someone who's at risk of delirium or recovering from a delirium. I think the strategy is the same. Eat, walk, sleep is now a strategy run from Queensland, a really neat hospital-based strategy for management of delirium. And then I think they're the two key things. And then making sure people are well. So that the final strategy, I suppose, is that we know that people with dementia have on average at least 4 other chronic conditions, be that osteoarthritis, diverticular disease, diabetes, airways disease, heart failure. And any of those, if they go off, are likely to precipitate a delirium. So regular medical review to ensure those chronic conditions are well managed would be another way to help reduce the progression or to minimise the length of the delirium, and also then minimise the risk of that delirium in the home-based setting.
Some really important points. Thanks, Mark. Jess, any other questions from our audience today?
Yes, we've had a couple of questions in. What are the best screening tools for delirium that can be used by healthcare professionals?
I think that's one for you, Mark.
It looks like it. Look, one of the most commonly delirium screening tools is now there's it's called the 4AT. It's a fairly easy tool to do, and it relies on it's called the 4AT because it's really just got 4 items to it. It's a simple observation when you look at the patient: is there a change in fluctuation of attention? And that fluctuation can occur in over a couple of hours, really. So you can see that change. Then it's just looking at whether someone can tell you their date of birth, age, where they are, and what day it is. And then it's telling you the days, the months of the year backwards, which is what we call it's an attentional task. If you think about doing it right now, you'll all get a bit sweaty and tachycardic. Your heart rate will go up because can I actually do it? If we ask you to do it with 1,033 attendees, then you need to, and then that becomes a score. A score of 1 is indicating cognitive impairment, and that could be a dementia or a delirium. A score of 4 is clearly a delirium. In between is a little more difficult, but in our hospital now we're saying any score of 4 is a clear delirium, and anything below 4 is cognitive impairment, and we will look for underlying dementia. We use the MMSE and clock drawing test as our favourite tool. I've used it for a very, very long time. General practice understand it really well, and so long as the clock drawing test is added to the MMSE, then you'll pick up the what we call the executive dysfunction, that planning and organisation stuff that happens in delirium quite quickly. And the clock drawing test is really lovely because it's either skewy or it's not.
Yep.
And nursing staff and care staff in residential aged care can see it like that. You can tell, and it actually comes as quite a surprise to people when they ask someone to draw a clock test, is just basically give people a big circle and say put the numbers inside and put the hands on 10 past 11, and they're quite surprised when it's really, really disorganized. And then they think, gee, I wonder how they manage with their catheter. Oh, I wonder if they know that they shouldn't be going to have a shower with their plaster on, and all of those sorts of things begin to click. So the clock drawing test is a really neat test in the hospital setting and sometimes in the residential aged care setting as well.
Thanks, Mark. Jess, I think we've probably got time for one more question.
Yeah, this one was a little bit earlier on and probably another one for Mark, but how do we differentiate between fluctuating attention in delirium and fluctuating attention in dementia and Lewy bodies?
Very good question. So for those who don't know, Lewy body dementia is one of the many forms of the etiologies of dementia. Remembering dementia, so I go backwards a bit. Dementia is a syndrome. It's not definable as a pathology. You either have Alzheimer's disease causing you dementia, or Lewy body disease causing you dementia, or Pick's disease causing you frontotemporal disorders. So dementia itself just describes a syndrome of cognitive change that fundamentally interferes with day-to-day life. So then that dementia, if it's caused by Lewy body dementia, under the criteria we use to clinically diagnose Lewy body dementia, which is caused not by amyloid and tau, which are the two proteins we see in Alzheimer's disease, but by a different protein called ubiquitin, which we see in where Parkinson's disease emerges, in fact, which is why it's a bit like Parkinson's disease. There is attentional fluctuation in that definition. I think the big difference is that fluctuation is persistent and there for a long period of time. And going back to when we started, think about change. The great thing in residential aged care is that staff know who they're looking after. And obviously there's changeover of staff, but someone would know, gee, Jack's different to how he was yesterday. And when that happens, and then Jack's fluctuating, I'd be thinking about delirium rather than, well, Jack's always had hallucinations and has been a bit odd. And, I had a lovely day with Lewy body dementia who saw 3 or 4 Greek gods. She knew they were there. She knew that they were part of her delusions, and she could tell me the purpose of these Greek gods when they visited, all the different roles they had. But so there is a fluctuation there with those hallucinations with Lewy body dementia, but then it's the change that I think is the trigger to help you differentiate between the fluctuations in dementia. And remembering in Alzheimer's disease-induced dementia, you don't generally see a lot of fluctuation until very, very late in the dementia. I mean, someone who might be unfortunately limited to their bed mobility and needing feeding, having cat naps all the way through the day because their sleep cycle is fragmented towards the end of their dementia, then will probably fluctuate. And to be honest, I don't think I could differentiate that from a delirium. But when someone unfortunately is at that end, what we may describe as the palliative end of dementia, then if they did acquire a pneumonia, that might be the more likely reason for them to pass away, rather than trying to actively treat that delirium. And there is a delirium associated with palliative care, so there's what's called a terminal delirium as well. So again, we probably wouldn't treat or try and get rid of that terminal delirium so long as the patient is not distressed. If they're nice and sleepy with their delirium, well, I think if they're passing away, that's probably comfortable for them.
Thanks, Mark. That's some really interesting points, particularly that idea of palliative delirium. I've got one last question, and I'll ask both Mark, you and Len, and I'll throw to Mark first. If you had one piece of advice for our viewers and listeners today, based on all that you've experienced, what would that one piece of advice be?
It would be look at the patient from the perspective of how their brain is perceiving their environment.
Mm-hmm.
Because I think if we do that, we can have empathy, we can share, we can really value the personhood of that individual. And this is very different to person-centered care. This is about understanding their personhood, them in their context of their biopsychosocial life and their life experience, because how they are demonstrating their distress in the setting of their delirium will be a reflection of their life experience. And if you can understand their life experience and see them not for their delirium, but for their person trying to deal with a distressing interpretation of their environment because their brain is not functioning like it should, then I think we'll help that patient a great deal more, because there's only so much medicine can do.
The person in the environment, really
Simple.
Yeah, it's simple, but not necessarily easy. Len, have you got any comments?
Oh, it's the same thing, isn't it? They look at the person beyond the patient, if you like. What I believe is that my advice to family carers would be that you ask questions.
Mm-hmm.
You put your concerns out there and ask questions, and not demand answers, but simply engage in conversations about what is going on. And I think you'll probably be surprised at the humanity that comes back at you, because people who care for others in the medical profession and in the caring profession are just that. They are giving of themselves to do that caring work. And I think we just need to calm down a bit and to share in that environment.
A really interesting point, Len, and I think Mark would agree that the clinical standards talk a lot about partnership with families and the people who know the patient best, and in some ways perhaps residential aged care staff are an extended part of the family sometimes. I sometimes wonder whether we are including both the formal family and the informal family quite enough in the way we approach, particularly Mark, when you were talking about that very holistic view of the person in their environment.
And I think one way residential aged care can support that holistic view and also best manage and look after older people is through a program that Safer Care Victoria has been driving. And I'll disclosure, I've been the statewide lead for this, which is the 4Ms project, which comes out of the Institute of Health Innovation and supported by Safer Care Victoria still in residential aged care, where there's 4Ms, and the first one is what matters, and that's what matters to the patient most. And then there's medications, which we know are a precipitant for delirium and can worsen dementia. Mobility, which is really important, not stopping people from walking, but encouraging them to walk safely and maintaining that dignity of their mobility. And then finally, mind. and mind is delirium, dementia, and depression. I think we would holistically understand and support older people in residential aged care so much better if we attended to those simple 4 M's. Some people want to add a 5th M, which is malnutrition or nutrition. It's as an N, not an M, but so I have to put it malnutrition, or meals, I think is the other one we've added. Yep. But if we could get those, they're simple, but if we do that right for every patient, there's evidence that it saves money. In nursing homes, we demonstrated that it saved money. In IHR, I've demonstrated that it actually saves money as well as has better health outcomes and quality of life outcomes for the patients, which has the dementia delirium story as well as that psychosocial model.
I love it.
Len, did you have?
I love it. It just struck me then that we've been going for an hour, and that's the first time that we've actually mentioned the words quality of life. Mm-hmm. And I mean, that's the essence of what we're talking about, is quality of life. So we can only provide quality of life if we come at this in an holistic fashion. So I'm all for it. I'm delighted that this is a subject of discussion.
Thanks, Len. Look, we might wind up now. I can't believe how quickly an hour goes. Could I thank Len? Your comments and your experience have been so valuable today to put that real frame around what we're talking about, but also Associate Professor Mark Yates. Thank you. I know you are extremely busy, and we really are grateful for you coming along today. I hope everybody has found this discussion as stimulating as I certainly have. Could I also, just while we're here, just thank Jess and Jim and Vicky and Jackie, who have worked in the background tirelessly. I'm just, I was going to say I'm just the pretty face who sits here and asks the questions, but that's probably not true. But thank you all for your untiring work in getting these webinars together over this year. We're in the process of planning the webinar series for next year, so we're looking at some really exciting topics. If any of our audience have got suggestions, please feel free to let us know. Could I also just offer my best wishes and hope that everybody has a wonderful Christmas and New Year. We look forward to seeing you again next year. Thank you all.